Good evening, everyone. I hope I'm audible. Thank you. And second day, second last session, we'll try and make it interesting. I have esteemed panel with me, and what we are going to discuss is the importance of digital health infrastructure and the necessity of digital health adoption in LMICs. And I'll first introduce the panel. To my left is Dr. Praveen Gidam, who's the former additional CEO of National Health Authority from India, which is driving the digital health component in India. Next to him needs no introduction, Pasataji. I think he's been on as many number of panels as we've had since yesterday. We all know him. He's the CEO for the Digital Transformation Office from Indonesia. Next to him, we have we have Walter, who is the ICT officer with the Ministry of Health from Tanzania. And last but not the least, we have Emerit, who represents USAID and looks after digital health for them. So to kickstart the panel, we've been since yesterday talking about the importance of digital health and how it can be an enabler when we look at universal health coverage and equity. And we also understand, along with that, that if we do not have the right kind of architecture around digital health, it can also lead to inequity, right? And in one of the sessions, very interestingly yesterday, the importance of a national ID for citizens was talked about as to how it is extremely important when we look at, implementation of digital health. And how it is an enabler as well, if you are looking at inclusivity to come into the service delivery as far as health is concerned. And it's the overall linkage, to the continuum of care which we talk about. And then next, we also heard as to how digital infrastructure is extremely important when we look at penetration of internet into cities and into rural areas in LMICs, and also the availability of smartphones and devices for use of digital health. And lastly, but not the least, I think we also discussed about advocacy and policy since yesterday as to how digital needs to be inclusive and be included as part of the policy infrastructure of any country. And last but, just to close this statement, we also talked about the importance and the gap which we have and the challenges which we face when we look at digital implementation at the primary healthcare level. Right? I think that's where the challenge is for LMICs when we look at community level service deliveries in terms of immunization, ANC and other services. To start the discussion, I would request Walter to talk about Tanzania, where they've gone in with a very structured approach. They started off their digital journey in 2013 when they came out with a policy document, which was then followed by a roadmap for digital, and then that was converted into a digital strategy for them, which is for 5 years now, from 2019 to 24. And they have gone into quite a bit of detail in terms of infrastructure planning, as well as looking at the institutional mechanisms which are required within the government to be able to support this in terms of sustainability. So my question to you, Walter, would be that what are the essential facets, when you look at planning for digital health in countries and specifically focused on Tanzania? Over to you. Thank you.
Thank you very much, facilitator. And of course, I just want to touch, regard to your question, of course, I'm going to touch the whole thing regarding the digital health. And the thing is, most of the country, or most of the places, when you say digital health, they normally leave aside infrastructure. They forgot, by the way. And of which digital health is a combination of both solution, software and infrastructure. And for us in Tanzania, what so far we are doing, by the way, our journey started way back, not only 2013, it was 2009, I think, 2009. So of course, in that time or period, we had several number of ICT initiatives. And of course, I'm going to use the slides. And as you can see my slides, we had several systems, and most of them, they were silos and fragmented. Why? Because there was no guidance. So, and you know, ICT is going very fast. So what we decide to do, we decide to come up with the guiding documents. As you can see, these are very few, but they're the main one. First, we had ES strategies, and it came out, it was 2013 to 2018. Now we have a new one, 2019 to 2024. Also, with the investment recommendation roadmap. We have got enterprise architecture. With this roadmap, by the way, this roadmap, it shows very clear what and where we are. Of course, where we're coming from, what we are, where we are, and where we want to go. So in this roadmap, we decided to come up with some, of course, few but key investment areas. And one of the area, two areas, is not only solution, but infrastructure. It is well defined in our documents, and we managed to now to start, guiding now the solutions, initiative for this, development and implementation of these ICT initiatives. And we put it very clear governance. And now, by the way, before starting any ICT initiatives, you have to undergo certain procedures. I've got this slide. As you can see, of course, through by having this digital strategy, we have National Digital Health Stand Committee, we have Technical Committee, we have Technical Working Group, and Digital Secretariat. So we have to go all these stages in order to start your initiatives. And of course, in this regarding infrastructure, in these documents, we also state very clear that how are we going to introduce infrastructure. Before coming up with a solution, you have to take a good care of infrastructure. In our country, we have like 4 or 5 levels. Of course, we call them reporting levels. We have national, we have zonal, we have regional, district, facility, and community. Of course, most of the time we forgot about community, but we also include the community in our documents. So we managed to lay in last mile connectivity fiber cable all the way from national to district, and some of the facilities, of course, especially for those which you can find in urban areas. And for PHC, the dispensary one, we are using normal mobile networks. So we have got many agreement with our MNOs in our country. We've got like 4 or 5 big. So they help us to connect, using their network in our ICT solutions, and they provide, by the way, free network, free connections, and some, of course, they give us a good number of SMS. For example, we are using mobile networks to report, to get report of AEDSARA, to Brexit reports. Some of the reports, let's say weekly report from dispensaries where, of course, it's very hard to reach area and no network, of course, no last mile connectivity. We are using mobile networking. It means we are using tablets. And once you're speaking about infrastructure, also not only internet, or reliable internet, but we also touch about the devices. For example, in our country, we are using tablets, and these tablets, what we decide to do is to come up with customized specification for our country. Device is a simple thing. It's easier to carry, Sometimes once you are going to give it to its provider, it's easier to take it home or somewhere else. So for us, what we decided, of course, we put the customized specification. For example, all our tablets that we are using in the health sector, they've got a trademark, interior and exterior trademark, and this one is from manufacturer. Even if you are going to reset to factory settings, it will come up with the trademark, the logo, and name of the ministries. And by the way, we are doing all this very close with stakeholders, public and, of course, private stakeholders, DPs and IPs, and, of course, once you are talking about stakeholders, even the users, by the way, they're the most important stakeholders. Most of the time, we forgot about users. You introduce, systems, sometimes even this infrastructure. We have to include them. For us, we manage to include them. We show them that this infrastructure is going to help you using the system, which will help you to, not only to collect information, but to have report which can help them to in their daily activities. And of course, in our country, what so far we decide to do and emphasize is the integration of our systems. Not all integration of infrastructure, because of course it's the same infrastructure in different systems. Now we are connecting different systems via, we have got the layer, the Tanzania Information Exchange. We call it, in our country, we call it Health Information Mediator. All big systems, they are communicated or integrated or share information via the layer. And the good thing about Tanzania, we have got IGA. This is an institution of which takes a good care of the implementation of ICT initiative in the government, not only health sector, but the entire government. So we are working very close under their guidance and their technical support. And so at the end of the day, and they're the one, by the way, who guide us on the even lay down of this infrastructure. For example, the entire country, how are we supposed to do, how are we going to connect, so that we are going to use the same infrastructure, not only for the Ministry of Health, even other sectors also. So let me end here and we'll continue with the discussion. Thank you.
Thank you so much. Thank you. Park Sitaji, I will move on to you now. And you've since yesterday been speaking in different panels, and you've been highlighting the diversity of Indonesia, right? You talked about 17,000 islands, the largest archipelago across the world in terms of population, 270 million. And the diversity in terms of that, about 6,000 plus islands are habited, and out of that, I think 55% of the population being only in Java. So that's pretty diverse, right? We wanted to understand from you that, the journey which you embarked on in terms of digital health. What are the challenges when you look at this diversity, and, what role does a robust national level digital architecture overall, which goes beyond health, play in the kind of construct which you are building for Indonesia?
Yeah.
Over to you.
Okay. Thank you. Okay. Thank you. Good afternoon. I think this is the third finals for me. Hopefully, you can more detail know about our journey and our strategies. Yeah, this is actually the current condition of Indonesia. We have all of our population now on the productive age populations. Yeah, you can imagine in 20 years later, this can be worse. Yeah? We need to improve our health infrastructures, our health service delivery, because in 20 years later, mostly our population more aging. We need more finance to make our people healthy. Because of that, very important thing is how we can improve now our health service delivery, and also how people more concerned about the promotive prevention rather than curative. Yeah, because of that, we have 6 pillars. I think this is already I mentioned about this. We need to concern to change our behavior people to promotive, because our spending of the health sectors increasing now, more bigger from the GDP. Because of that, the important thing is how we can improve and also accelerate the health service delivery more productive and also more efficient. Because of that, this very important thing is how we can improve our digital transformation, especially in the health sectors, to focus in this support, to support in these pillars. Yeah, this is our journey, how we can make like some digitizing the health from the beginning of life. We need to concern about that to make sure the sustainability of the recordings from the beginning of life. So from the baby, when the mothers pregnant, so we need to monitor about the about the current conditions, because we have also some issue about the stunting. We need to decreasing our stunting. So the important thing, how we can monitor every mother's pregnancy, and then also after they born, to make sure the growth of the baby is continuing still normal. And then because of that, we need to record the healthy activity it's of our patients. We not only in the physical activity, but also in the virtual. So we combine within the virtual and also the physical. Because as you know, as I mentioned by moderators, we have 17,000 islands. So the telemedicine is very important thing to build in this, to build the biggest capacity in this there. And then the important thing also, how we can connect within the wearable device. Because of that, we need to build or develop the infrastructures to serve this initiative. Yeah? Not only coming from the health facility as physically, but also in the virtual using the telemedicine. Until now, we have more than 20 providers of the telemedicine. This is coming from the startup. And then we need to combine within this initiative, and then also within the health facility. And then also connect with the wearable device, because very important thing to get connect with this device to get the vital signs, etc. Yeah, this is our journey till 2024, and then next year we will continuing to develop the new blueprint until 2029. Because in 2024 we have some big event for new elections to the new presidents. Because of that, we need to still continuing our journey. Yeah, we focus about the three, how we can develop and integrated all the scattered data coming from the health facility. As I mentioned before, we have 60,000 health facility, mostly coming from the pharmacies. Because of that, very challenging actually, how we can integrate all the health facility, different system, different vendors, etc. Because of that, we developed the architecture in the last year, and we launched the blueprints. In the blueprint, we have some guideline. This is like a reference or guideline for each vendors, for each health facility to follow, to comply within our standards, and then also our journey. And then the second thing is about how we can integrate all the applications in each health facility, also from the startup, from the others innovators, to comply within our system. And then also the important thing is how we can engage the more stakeholders. The more stakeholders, and also national and local governments. As you know, we have 74 provinces, now increasing into the 37 provinces, and also we have the 500 local governments. So we need also to gather within these local governments and also the national level, also in donors and implementing parts like a USAID. I think this is the very strategic stakeholder for us, and also CISU, and also domestic and foreign private sector entity within Indonesia. By bringing this together of a group stakeholders, I think we believe we can achieve this target. Yeah, this is our platform. We already launched in the mid-years in this year, on July. This platform actually contain within the health information exchange, like health SL7. And then also we put in this platform many standards, for example, like ICD-10, SNOMED ID, login, etc., to make sure that each application, each system comply within this standard. And then after we connect, actually the patient can get their data using the application. As you know, we already have the COVID app application. We call this Peduli Lindungi. Peduli Lindungi itself already downloaded by 100 million people from Indonesia and also the foreigners. And we still continue using these applications and we transform not only just a COVID, but also all the disease can be input in this application, and also can be connected within the wearable device. So with this initiative, we can put more incentive or reward for the people to change their behavior into the promotive and prevention. For example, if I walk every 5,000 steps every day, so I give you some reward. You can get like a multivitamin for free or something. Yeah. This is a very important thing to build the application and gamification for the people to change their behavior to support this initiative. And then the other thing is about how we can integrate it within all the health facility, not only virtual but also the private, the physically health facility, to make sure the doctors can access the medical record of each patient. Yeah. Because very important thing to know more about the current situation or the old situation of the patient, yeah, for example, like allergics and also others disease, so the doctors can give him the comprehensive medical treatment. And then the other thing is the government. The government no need again to ask all the health facility, all the government for the data, because we directly got the data, current data. Actually, we already use this when the COVID-19 arrived there. So we use this platform and expand this platform to make sure the government can get the data. And then after this, actually, we can detecting or predicting some issue or some new disease in Indonesia. And then the other thing, the important thing is how we can build the ecosystem. Because a very important thing, because the government cannot run by itself, so we need to engage more people, more startups together with us to accelerate this initiative. As you know, we have the 60,000, so we with the many startups, many vendors together to accelerate this initiative. And then until now, we already connected with the 7,000 health facility. This is in 3 months. So we focus now in Java. Java Island actually cover more than 60% of population in Indonesia. So in the next year, we move to the other islands to finalize our strategies in the 2023. Yeah, I think this is very important thing to also to build to make sure the regulation support this initiative, not only the blueprint but also the law, the regulations to support this initiative, and then to make sure the all ecosystem moving together with us. Yeah, I think in the last, what very important thing is the COVID-19 is make a wake up call, yeah, for us, yeah, before the information, the data scatters in others health facility, but after the COVID, we have like some boosters, yeah, to accelerate this transformation. I think this is as a momentum, like we already have some issue like economic crisis. So I think this is a good momentum to accelerate the digital, especially in the health sector in Indonesia. Thank you.
Thank you so much. Emrit, moving on to you, you represent the donor landscape, and you are engaging across a number of low and middle income group countries. So from your perspective, what do you think is the importance and the impact of digital health investments when we look at the last mile or the primary health care? Thank you.
Thank you. Whether we call it the last mile or the first mile, reaching people where they are is absolutely critical to achieving health equity. And I was really thrilled to hear Atul Gawande, USAID Global Health Bureau's Assistant Administrator, put it in his own words in the keynote address yesterday. Yes. He was saying that our job is to learn how to deliver town by town the capacity to extend lives, save lives, and preserve quality of life, and that we cannot do it without digital health and digital health innovation. And as somebody who spends all of her time thinking about digital health, that was a really exciting thing for me to hear coming from my leadership. However, we all know that digital health and digital technology is never going to be and never is a silver bullet. So in order for digital health investments to actually have that impact of promoting health equity, we need to be thinking about how we're investing and supporting those investments through things like investing in the enabling environment in which digital health interventions are taking place. So thinking about skills building, thinking about the governance and the policy and the regulatory frameworks that can set digital systems up for success. Thinking about the broader change management processes that we need for digital interventions to really serve both the patients and the health workers involved. So with all of that in mind, how can we design our investments to add value and to really help reach everywhere, everyone that needs to be reached? So the first thing is around understanding the unique needs of enabling environments where these interventions and systems are in place. So thinking about what kinds of challenges health systems are trying to address, thinking about if there are detailed assessments that are already available that look at things like systems and capacities, really trying to understand the enabling environment before layering on any sort of digital tool or digital intervention. And this can include understanding the quality and the reach of digital connectivity. As a sector, we've done a great job in thinking about offline first solutions, but at the end of the day, data still needs to travel. So you need to be cognizant of where there is connectivity. And USAID has two initiatives that are looking to support this. And this one is Digital Invest, and the other one is HETA, or the Health Electrification and Telecommunications Alliance. It also includes for us thinking about what kinds of digital systems are already in place in country. And that's something that PMI, the President's Malaria Initiative, has done in looking at digital community health initiative mapping. So seeing where there are digital technologies that are being used already to support community health workers, as well as for things like data collection and reporting, and then using that data to support decision making. So that's one area. A second area is by focusing investments holistically. And I mean holistically in terms of thinking about the people involved and also in terms of the systems involved. So what I mean when I'm talking about thinking holistically about people, we want to see the whole person as opposed to isolating care systems based on disease or wellness verticals. And this is something that we in the donor community need to continue to improve on. So this can involve one approach to taking this more holistic approach can involve really strategic planning amongst donors and partner alignment, and what all of my colleagues on the stage have mentioned thus far. Those are the kinds of processes that USAID and other donors need to be supporting and aligning to. And another element, again, leveraging off of what has already been mentioned here, enterprise architecture is a really fundamental and crucial way to help make sure that we're taking a holistic approach towards the people that need care as opposed to thinking about things in vertical systems. And we need to rationalize the number of systems that are in play. The slide showing all of the different health interventions in Tanzania from 2017, I think, is a really good example of that. That doesn't necessarily serve clients and patients. It might serve reporting needs, but it doesn't make it easy for a client who has multiple health concerns, as we all do, to really navigate systems. When I was talking about whole systems, I was thinking also about the fundamental digital public infrastructure that can support investment. So it's things like digital identity and digital payment systems, and these kinds of tools that can enable digital systems to best serve patients with all of the necessary data and privacy protections as well. Finally, remembering that our primary healthcare workforce, so the frontline health workers and the community health workers, are absolutely critical. Again, Atul Gawande in his keynote address spoke about how there's evidence showing that health workers need support systems to make improved primary care possible. And again, I was thrilled to hear him say just how critical digital health systems can be in supporting these frontline health workers. There are a number of ways that this shows up. I think the most common way that I think about is in terms of job aids and reporting and data collection. But another interesting way that digital tools can support primary healthcare workers is around facilitating bidirectional communication. And that sometimes can create the psychosocial support that community health workers need as they do a really difficult job and sometimes in quite dangerous situations. So focusing in on our frontline health workers and our community health workforce can really play a critical role. And another point that I'd like to emphasize is that the community health level system, that care at the last mile, all of that needs to also integrate up to the ministry level. And so a lot of what USAID talks about, a lot of what I spend my time thinking about and talking about is national digital health strategies and national digital health architecture. But all of that really only becomes meaningful when you're thinking about that patient level interaction and the health of individuals within a population. We also need to be thinking about how digital infrastructure can meet a large variety of needs. And this is tying back to the comment that I made earlier about digital public infrastructure, because a new mother might also have postpartum complications, and she also might be involved in agriculture, and there might be a drought, and her life is really quite complicated, and she might be relying on digital cash transfer programs to be able to access funds that she needs in order to take public transport to be able to be seen at a specialized care facility. So we need to be thoughtful and aware of the complexities of the systems that we're operating in. And one, I think complexity is obviously a difficult thing to tackle, but there are two perspectives that I'd highlight, and I think we've heard about this a bunch, that standards are crucial for enabling all of the complex interactions that need to take place within a healthcare system to really smooth those data flows and smooth the movement of information. And second, from the perspective of care delivery, we need to be thinking about human-centered design, which of course is no news to anybody here, but really thinking about users and patients and centering the programming that we're doing around those two key populations. And with that, I'll hand it back. Thank you.
Thank you so much. Thank you so much. And I think I have picked up one phrase from you, changing the last mile to the first mile. I think that's an excellent point, and I think an extremely important point you brought in was the citizen centricity to it, right? I think that's, we keep looking at systems from the government requirements and the system and the stakeholder requirements and largely miss out, the citizen centricity to any kind of a digital intervention. Great points. Thank you so much. Dr. Gidam, moving on to you. In India has taken leaps and frogs in terms of digital public infrastructure when we talk about a nationwide citizen-based ID. I mean, we have IDs across 1.3 billion people in India. She talked about, a universal payment interface, which is again available and again one of the largest in the world. We have probably the largest, digital payment being made for social good. And of course, the COVID platform, which was created in terms of capturing the vaccination, having more than 2.1 billion doses being captured on that. So there are great. What is the significance and how can the digital public infrastructure be used, and how are you using it to build the next phase of the universal health interface, and if you can dwell more on the DCX in terms of the claim exchange which is coming up in India, and to how are you integrating the private and the public sector together when we look at the entire digital landscape of India?
Thank you so much. And as rightly pointed by you and the earlier speakers, the role of digital public goods, a good national digital health strategy and understanding of the context is very important when we chalk our way forward in the digital health journey of any country. So all of us know that digital health is a very diverse, complex kind of ecosystem with different requirements from different stakeholders. Citizens want health locker or discovery and payment and booking of services, and doctors want EMR or teleconsultation facility. Insurance companies want kind of payment features. So there is no one size fits all kind of solution. Everybody must be allowed to use whatever solutions they want to use. India presents an additional complexity, 1.4 billion people, spread over 36 states and territories, and health is managed by state and not by federal government. So it's an additional complexity. 22 languages which are officially used by the government, and a huge rural-urban divide, a huge private sector, and tens and thousands of a very fragmented healthcare ecosystem. So the key here is to understand this reality and not push anything from top to bottom, but to understand this and integrate it in a very seamless manner. The issues pertaining to digital health are numerous, like there is resistance, it is not a priority in India because we still will probably decide that to have additional number of beds is probably a more important thing. So we have to be very frugal and understand the budgetary constraints also. Authentic data, the single source of truth. So I told we had 36 territories. All states used to have their own registries of doctors and healthcare professionals, and we have 5 and 6 different systems of medicine. So you multiply those 150 odd registries. So how does a teleconsultation company knows a particular person approaching him as a doctor that he is actually a doctor? So that single source of truth is very important. And then lack of interoperability, privacy, security concerns are very well understood. I will not repeat it in this particular audience. But all these encompassing issues where we decided that it should be addressed by a common strategy, and that's why the Digital Health Mission of India was launched, and this was done at the peak of COVID pandemic. That was the time when the transition and acceptability to digital solutions was seen increasing dramatically. And pilot was launched in 2020, nationwide rollout was done in 2021, and certain guiding principles like inclusivity, because there are many areas which are far-flung. Then the architecture should be federated, no centralized database, but with the proper interoperability and standardization. And these principles were decided, the administrative setup was set up, and we started building on the top of our existing digital solutions, which are very scalable, frugal, and robust. So India has already provided a unique digital identity to every single citizen of the country with all the biometrics, fingerprints, iris, and face captured. And the health ID was built on the top of it, but we also understand that there is a possibility that a citizen may opt out of digital identity, or a foreigner may also come. So it is not a mandatory thing to have a digital identity. It can be built without this particular Aadhaar or unique biometric identification. Then payment network is also seamlessly now integrated. It was recently launched, but now it is clocking 7.3 billion transactions in a month, which is more than 10 times the card transactions through MasterCard and Visa, which are basically private companies. But this is a protocol which enables transactions across banks, digital wallets, and financial institutions in a very seamless manner. Then COVID vaccination was also done on a public platform, which is known as CoWIN, and so far we have clocked 2.1 billion, and I remember on a particular day, we had clocked 25 million vaccines in a day. So that's the scale, and this CoWIN portal has kind of created a unified database. But this is possible for vaccination, but it's not politically and from security point of view, technology point of view, an acceptable solution for having a centralized database is not something which will sell well in several instances, and that's why the importance of federated architecture is there. So how does it work? We have this common interoperable platform which connects disparate solutions. Right now, 1,000 plus solutions are getting connected, and some of them have been already connected. So it works like this. If you are going to a government hospital A, then you go to a private hospital B, and you have your own health locker, say G, in your mobile app. So through this interoperability platform and common protocols, you can pull the records, store it in your mobile, or even if you don't store it in your mobile, you go next to say general practitioner C, you can give consent to the C person to fetch the records from A and B. So that kind of interoperability is the essence which we have developed, and we are taking it to the next level. This is a slightly detailed representation of that, but at the center of it, there is a health information exchange and consent manager. Nothing moves without the consent of the patient, which can be granular. And health ID and unique identities to facility and professional ensures that this happens in a very seamless manner. And these digital public goods are basically created to ensure that the digital silos or moats which exist in several platforms, like you want to purchase anything from Amazon, seller has to be on Amazon and purchaser has to be on Amazon. Otherwise you can't purchase. So that kind of network effect leads to oligopolies or monopolies, and which is then very difficult to break. And a kind of system that we want to have is kind of democratic, transparent, like email. You can't send message from Facebook to WhatsApp or WhatsApp to Telegram, but you can send message from Hotmail to Gmail to Yahoo, because there is a common protocol, SMTP. So we wanted something like that to happen in digital health space. So next stage after the unified payment interface is unified health interface, which we have built and we have tested. So the architecture is the key thing here. So we built on the top of horizontal public goods. Then we developed public goods specifically for health, and then we allow players, government, private, anybody, to plug in their systems, their solutions of any type. It can be insurance related, health record related, laboratory related, into this particular system to facilitate all this interoperability, which then makes it possible to have any person develop its longitudinal medical record, which can be shared with his or her consent to anybody. And also it helps policymakers, researchers, clinicians, if you suitably anonymize and aggregate the data with consent to create various analytical patterns, understand epidemiological trends, do research, and so on and so forth. So far this is a recent initiative, as I said, launched nationwide in September 2021, and we have created 280 million plus digital IDs for those many number of Indian citizens. And we are onboarding facilities and professionals. It started linking records. More than 1,000 integrators are getting integrated. And one-stop solution app, which was, there was an app which was developed for COVID tracing, contact tracing, which has 200 million plus downloads. It is now getting converted, and I hope it will be done in next maybe 2 months, into a single stop solution for search, book, avail facility of doctor teleconsultation, and it will also serve as a health locker. But this will be one of the apps. We don't say that we will force anybody to use any digital solution. It's a kind of choice which is with the user that we believe in. And therefore this particular architecture enables all the spectrum from wellness to health, from prevention to treatment, with the allied stuff like ambulance, health insurance, etc., across all the systems of medicine, and develop the products which that particular startup wants to develop, where his skill lies, and for the particular type of user based on vertical specialized approach for a specific disease, or horizontal approach which can be like a broad based, or in different permutations and combinations. So this kind of unlocks the potential and also reduces the entry barriers which are existing, and that innovation is enabled because of this particular architecture. So going forward, what I am suggesting from here, we just discussed about the importance of digital public goods, the architecture, and the experience from the India, which has extremely complex and heterogeneous ecosystem within the country. And this is a plan we learned on our way from several countries. We were like searching and discussing from various countries. So here going forward, we also offer. I am currently right now in Harvard. I continue to be a officer of Government of India and also associated with MIT and Reform for Resilience. So we would like going forward to collaborate with any agency who is working in the digital health or any government to offer the digital public goods or the key concepts how we built to any country or region, and also for providing policy guidance and technical support to create that kind of vision or a blueprint which will ensure that the growth in this sector, which is bound to happen, government may or may not intervene. If it doesn't intervene, it will lead to oligopolies and lack of interoperability. So this is the time when we must intervene and have policies in place in countries so that things move forward in a very unified, synchronous and interoperable fashion. So that kind of collaboration, the Government of India and my other institutions, we look forward to have with those who are willing to. Thank you so much.
Thank you. Thank you so much, Dr. Idham. I think this was very, very inspiring. And the numbers which you flashed, I think, puts the context into place. Right, thank you so much. Before I open, the question and answer session to the House, I have one question to the entire panel, and whoever chooses to answer that can probably take it forward. We've discussed digital initiatives and architectures and the progress which has been made across 3 countries, across continents, and we understand that every country has its own set of requirements, and therefore there is a requirement of customization of solutioning and the architectures as well. And we, on the other hand, we have the open source applications, and we know their potential. It has been used across. We know of DHIS2 platform, the ComCares, and COVID is one example where DHIS2 I think was very extensively used across the globe. And we can imagine, had that platform not been there, it would have been very difficult for quite a few countries to be able to manage the COVID response. Now, how do you think and what is the scope for these open source platforms to fit into the customized architectures which the countries are now, moving to? Is there space for them to be adopted? Do they play a role in this, or are we? Are we looking at these platforms probably not being getting integrated onto the architectures of the countries, and they are all compliant. They are fire compliant. They are HL7 compliant. So. And there are costs attached to when you are building architectures and solutions in the country. So how do we look at this kind of an integration happening in the architectures when we are looking at customized architectures? Over to the panel, whomever wants to take this on.
Yeah, I can take it on.
Yeah, sure.
So I think this is a very key problem that you have flagged. And first and foremost, my view is that we should go ahead with the globally accepted standards. Such as FIRE or SNOMED City or ICD, but then it doesn't solve the problem to a complete extent. The problem that we faced, for example, in India, we have a system of medicine called Ayurveda. Yoga is popular, and there are no codes in ICD or SNOMED for these particular systems. So we have to have country-specific extensions which are in general in similar line or similar tune with international codes and international standards. Second, FIRE and such other components generally talk about how do we shift data in JSON or similar other formats. But video consultation has also emerged very strongly. So how do you ensure that Zoom can connect with Skype or some WhatsApp video call? So WebRTC is the underlying protocol which most of these companies follow. So what we have done is we are developing it in open fashion on GitHub page, calling our startups. So India has around 80,000 startups, maybe third largest in the world. And out of that, 7 or 8,000 are working in digital health space. So this journey has been done while taking them along. So we want to reach a stage where it should be internet of digital health. Who owns the internet? Nobody knows. Somebody started with HTTP, TCP, IP protocols, and it developed, evolved. Nobody owns it. So something of that sort has to be done. But there is one ownership which I think government should take, and that is of ensuring that the registries are maintained in a very reliable fashion. For example, registries of healthcare professionals, so that across the border teleconsultation can be facilitated, and registries ensuring the identity of a person. The rest of it has to go in a very open, transparent fashion. We have started health information exchange at government level, but our architecture enables, if some other HIE comes into the picture, we enables that to come into picture.
Thank you so much, Doctor. Anybody else who wants to put in remarks or comments, or else we can open the house for questions from the audience.
Yes, hi. Thanks, everyone. That was really interesting, so thank you. I wanted to ask quickly about the federated structure, because I'm working on interoperability layers as well, and one of the problems we face is, or challenges, let's say, is around access. You can't just sign up and suddenly have access to somebody's EMRs or patient records. So how does the government approach that? Because you don't want a system that's so restrictive that people wait years for access, but you don't want one so open that people's privacy is compromised. So how do you ensure that enough people get access who need it, but also that they only get access to the data that they actually should be getting access to?
Interesting question.
You want to?
You want to attempt in terms of, he talked about the consent framework, right?
Yeah.
He was talking about as to all records getting shared with the consent of the patient or the citizen. So there is no, and it is a structure, which is flexible. So you could share one record for a specific duration of time, and you could share any number of records for any duration of time or for lifelong, right? And I think Sataji mentioned, the regulatory framework, I think, which is very essential when we look at consent management and what's the framework with the government, with the specific government in terms of privacy and citizen ownership of data. And this goes much beyond health, actually. It's not only restricted.
Yeah, to add to that, India has now developed in last couple of years a health data management policy which talks extensively about this concept of consent, and that digital artifact or the consent artifact is also developed, which is centrally located with the government. And as I said, it is for anybody else also to develop it. The granularity is not only about the type of record, that you can see record A but cannot see record B, that is one granularity, but also about the purpose for which you can see it. So you can share the consent for providing healthcare to me, while at the same time untick that I don't want to share the record for research or some other purpose. So the easiest solution which can be politically acceptable is probably to give that control of that data with the patient. Otherwise, if you give it to clinics, hospitals, or insurance companies, it is bound to create unnecessary controversy, and nobody will probably make much criticism if that ownership of consent remains with the patient or his caregiver.
I think we had another question from somewhere at the back. I saw a hand being raised. Any other questions, or we can give a couple of minutes back to you all? Okay, so I'll quickly wrap up if we have no more questions. And I forgot to introduce myself, so I'll take the liberty of first introducing myself and then probably come on to the. I am Samir Kanwar, and I am the Director for Digital Health for South Asia Path. And now I'll come on to a couple of closing. I think a wonderful discussion, and We're very, very articulate, and it's very heartening to see, 3 country directors sitting here talking about digital transformation in countries. Key points which I think came out very strongly were, government level ownership, institutional mechanisms to be placed within the government to be able to handle digital transformations. Right, standardization came out very loudly, right, we need standards. I think another point which was extremely important was a life cycle approach when we are looking at, and I think this point came up in one of the discussions yesterday as well, that we need to capture, the birth of the child and integrate it onto the health system at that point in time and take it forward from there. Interoperability, I think, hits us very, very strongly. Citizen centricity, again, I think is the core, and I think an extremely important point which came out was the BCC aspect of when we are looking at digital transformation and the capacity building pieces for the stakeholders, the behavioral change communication as far as the citizens are concerned, and the stakeholder engagement in terms of building capacities to be able to handle digital systems and specifically, at the field level. I also take this opportunity to compliment 2 gentlemen sitting here are from countries, which are handing over the presidentship of G20, Indonesia to India.
Offer for you.
Right, and I think, when we look at federalism and a multi-country cross-learning, and this is one of the platforms where we are able to connect as health experts and exchange views and do a bit of cross-learning. I think we need to move from regions to multi-country cross-cutting learning platforms coming up, and probably G20, which as of now does not have a health track, probably needs to look at it, and it will be a good platform for countries to engage and exchange learnings from as far as digital health is concerned. And with that, I end the session and hand over 10 minutes back to all of you, and would like to join me in thanking all the panelists who've given excellent presentations and the backdrop of what excellent work has been done in their respective countries. Thank you so much. A big hand to the panelists.